Okay, here's my video on Haemophilus influenza. I will point out that the sketchy video for this one is actually really good. I think it's really complete. It's a little bit longer than some of their other ones, but I do think it's a good video. They do get two things wrong in it, and it's really just pronunciation. Instead of it being factor X and factor V, they call it factor 10 and factor 5, but that's a minor detail. Otherwise, I think it's pretty good. So you might check that out just to hit some of the main points, but I'll go through them here as well. Okay, so Haemophilus. Mainly we're going to talk about diseases that are associated with Haemophilus influenzae or influenza type B. But here's the thing, influenza type B, there's a vaccine for it. So we don't see this one too often unless we're talking about unvaccinated individuals. And even then we're talking about unvaccinated children more than anyone else. But that said, there are actually several Haemophilus strains. I think there's A through F. And there's also a couple of different Haemophilus organisms. So we can see this in kind of a variety of ways, and actually the amount of invasive Haemophilus infections that we're seeing to serotype A is actually going up. And that could just be because we've been vaccinated against B for a long time that now A is growing out. But anyway, this is just to kind of cover the bases. This is a small pleomorphic gram-negative coccobacilli. So you can see here all these tiny organisms. These are all Haemophilus organisms within a sputum sample of actually somebody who had a Haemophilus infection. It's kind of a fastidious organism. It requires growth on chocolate agar with factor 10 and factor V. So factor 10 is actually hemin, and factor V is actually nicotinamide. And the nicotinamide is actually designed to reduce toxins that are produced during its growth. So that's kind of what it needs in order to be able to grow effectively in culture. But as long as you have those things, it actually grows quite well in culture. It's a facultative intracellular organism, which is actually part of how it is able to establish invasive disease. Its ability to grow within endothelial cells allows it to cross the, or in epithelial cells, excuse me, allows it to cross the epithelial barrier. And it is spread by aerosol transmission, although we see actually colonization of the oropharynx of most children by many Haemophilus species within the first couple of months of life. So it's a fairly widespread organism. Okay, so how does it make us sick? Well, like I said, it colonizes the upper respiratory tract within the first few months of life. And that's not just Haemophilus influenza type B, that's actually all of the, many of the Haemophilus serotypes are able to do this. And then once it does that, it is a gram-negative organism, so it has LPS in its cell wall. And the LPS is actually really capable at impairing ciliary function. And that's basically going to lead to damage of the respiratory epithelium, which is important for how it's going to cause invasive disease. So then the bacteria can spread across the epithelial barriers, leading to bacteremia and dissemination throughout the body to distal sites, most notably the brain. Haemophilus influenza, especially type B, was associated with meningitis prior to the advent of the vaccination. This process can be inhibited, though, by IgA. So if IgA was able to bind to it and the cilia were working, then it would be able to bat it out of your respiratory tract, no problem. But Haemophilus is smart. It's one of the 4 organisms that has an IgA protease. So basically it's breaking down one of our best defenses against this organism. So it's pretty tricky. So that enables it to survive. And as I said before, it's able to survive within epithelial cells. So if it basically breaks down your epithelial cell, gets in there, it can survive in here happily and then go back out the other side. And now it's in the bloodstream and can head on up to your brain. So it's pretty simple pathogenesis for being very capable. The other thing it has is that it has pili and non-pilous adhesins, which basically allow it to stick to the cilia, which is part of how it impairs the ciliary function. So what are we talking about when I say clinical syndromes? Well, there are a lot. So first off, otitis media, ear infections, and sinusitis. It's actually still one of the biggest causes of sinusitis and otitis media. And remember, even though it's vaccine eligible, one, the kids don't get this vaccine the day they're born. So there's a couple months where you're not protected from HIV. The other thing is, remember, there's numerous strains and the vaccine only covers HIV. So this could be a different strain of H. flu that's still causing ear infections and sinusitis. So it's also one of the #1 causes of parents missing work. Primary pneumonia is pretty uncommon in children and adults with normal pulmonary function. But if you have patients who have some sort of pulmonary disease, COPD, asthma, cystic fibrosis, these patients are pretty frequently diagnosed with basically an exacerbation of bronchitis and sometimes frank pneumonia. So it can cause some lower respiratory tract issues there. The big one, the big scary one, I guess, or one of the big scary ones, is epiglottitis. This is basically a significant swelling of the supraglottic tissues. And the tissue will appear enlarged and often cherry red, and on an x-ray it might actually show a thumbprint pattern from this enlarged epiglottis. This is actually a life-threatening emergency. This is a big deal because what happens is that if it occurs in unvaccinated children, it's going to occur in a child that's about 2 to 4 years of age, and the epiglottis will swell such that the child will have difficulty breathing, which will obstruct the airway and basically lead to death. Incidence of the disease is virtually absent in vaccinated individuals and almost never seen in adults, but we do worry about those 2 to 4-year-olds who have not had the vaccine. And then obviously the other big guy that we got to worry about is meningitis. It was previously the most common cause of pediatric meningitis. Thankfully, no longer a major concern of pediatric meningitis, thanks in large part to the vaccination. But we do sometimes see it in unvaccinated individuals where it leads to spread of organisms from the nasopharynx to the blood and then the meninges. So for this initial presentation, you're going to have a 1 to 3 day history of a mild upper respiratory tract infection. And then the patient is going to display normal signs of bacterial meningitis, so headache, fever, nuchal rigidity, and then the standard profile for bacterial meningitis. So when you do the CSF tap, the spinal tap, you're going to see a lot of neutrophils, so high PMNs. You're going to see kind of a higher than normal glucose concentration, and you're going to see a lower than normal protein concentration. If you see this trifecta with the other symptoms of bacterial meningitis, that's a really good indicator that you have bacterial meningitis. As long as we treat the patients promptly with antibiotics, you got a good chance of survival, only a 10% mortality rate. And this one used to be a big deal in asplenic patients and sickle cell patients, although Dr. Kent these days will tell you that this isn't something we really worry about, largely because vaccination. So what about that vaccination? Well, as I mentioned before, it covers Haemophilus influenza type B. It's a really great vaccine. Children receive the vaccine between 2 to 18 months of age. So they get 2 to 3 doses prior to being 6 months of age, and then they get a booster dose at 12 to 15 months of age that provides much more long-term coverage.